Hi, I'm Dr. Rudy Cashman, neurosurgeon, Fort Wayne, Indiana, for 44 years at age 39. Tonight's show is going to be very interesting. I have a guest with me, Dr. Erick Rivas, a trauma surgeon from Rivas Hospital. I was going to have actually two more surgeons, Dr. Reed, he was in charge of the program, and Julia Santa Rosa, a trauma doctor, but guess what they're doing? In surgery with the trauma, so they're not here today. But tell us a little background of yourself, Dr. Rivas. Where did you go to medical school, or where did you train? And,
sure.
And, I'd be interested in hearing that again.
Sure, no problem. Well, like you heard, my name is Erick Rivas, and my training primarily took place in Michigan State University in the town of East Lansing. Mm-hmm. So I went to medical school there, and went on to complete a 5-year surgery residency as well with Michigan State University, which actually we trained at several different hospitals throughout the state of Michigan. And after my training there, I decided to also do a fellowship. So I spent another year at the University of Michigan in Ann Arbor.
Yeah, you've been going to school for a long time.
Long time.
But you look happy and healthy, so this is great. Welcome to Fort Wayne.
Thank you very much.
Yeah, I've been familiar with Dr. Reed a lot longer because, 44 years I've been doing this, and I just retired from neurosurgery on July 1, but I'm now the wellness director, the medical wellness director at Rivas Hospital. How about that? So continue the line of things that I've learned a great deal about. My other shows, of course, have been about that. Tonight, we're going to review trauma, what the injuries have been for the last year or so, the incidents, type of injuries, prevention, and also sort of what I myself experienced over the years. This is going to be really a fascinating show, and again, trauma is preventable, not always. But a lot of the time, so this, listen carefully because this is going to become very interesting. Give me a general review of what you've been looking at in the last few months.
Sure.
In the past year, some statistics,
Absolutely.
whether it's decreasing or increasing, and I'd be fascinated to know that, Dr. Rivas.
Sure. Well, I guess let me start off by telling you that overall, the number or the statistics for trauma have actually increased as a group. So we at Lutheran Hospital have seen quite a jump in the numbers.
Is that right?
Absolutely. Dr. Reed, as you mentioned, is the trauma director out there, and he's been there for 6 years. Lutheran is a level 2 verified trauma center. And since he's been there, the numbers have increased significantly.
So I think some of this is incidents, but I think some of this, to be honest with you, got to be Dr. Reed. The first time I met that guy, I just loved him, and I think it has a lot to do with that too. And because he is just, I think, a great person, individual, and really developed a great system, brought in many good surgeons like yourself aboard. And tell me a little bit, what area is the Rivas Hospital Trauma Service covering? How many counties are we covering?
Well, there's actually about 16 counties that we're covering, most of Northeast Indiana, as well as a few counties in Ohio. Just to name a few, LaGrange, DeKalb, Noble, Kosciuszko, Whitley, Allen County, of course, and so on. And in Ohio, we're actually covering Van Wert, Defiance, and Paulding. So
that fascinates me because originally many years ago, after practicing with another neurosurgeon 6 months, I don't know what happened, but the partnership broke apart. So to make a living, they had 5 great neurosurgeons here, so it was not easy for me. 3 kids I had. You know what I did? I opened clinics in Van Wert, Paulding, Bryan, and Defiance, and I was the first doctor to do it.
Fantastic.
Yeah. So that really started a wonderful relationship, I think, with these counties.
I was going to say, so Ohio is definitely one of our partners.
Every farmer living out there knows me. I'll probably operate on them. That's fascinating. And you have about how many helicopters do you have?
So there's been primarily 1 helicopter, but we've recently added a second that's due to go live in probably about a week or so. So we'll have two full.
And that helicopter will be out at some hospital somewhere ready
Correct.
to go.
So one is actually stationed at Lutheran Hospital, and then we have another one that will be stationed at Wabash Hospital.
At Wabash Hospital.
Or the airport, rather.
Yeah.
And that way we can cover
have a real
the
quick
sites a lot
response
quicker.
time,
Correct.
because you're running on a clock, aren't you?
We are.
I mean, the whole hospital is really set up for trauma. We get a phone call, and overhead we hear it's a level 1 or whatever the level of trauma is, level 1 or level 2, and the emergency room gets ready, the doctors get ready, the operating room gets ready.
And the neurosurgeons oftentimes.
And the neurosurgeons run into the hospital.
Sure.
Or in the hospital to get alerted.
Actually, if I could, I'd like to tell the viewers sort of what happens when a level 1 or 2 trauma gets activated, because many people wonder what I do. They ask me, do you hang out in the ER all day, or are you in the operating room all day? And it's actually a little bit of everything. But what happens when there's a significant trauma, and there's a list of types of injuries or mechanisms of injury that occur that if the patient fits that category, they will be activated as a level 1, which is the most severe, level 2, which is a moderate, or a level 3, which is rather a lower intensity trauma or mechanism of trauma. So generally, it'll be the EMS that will call the emergency department and let them know what they're looking at, and the emergency department physician, based on this algorithm that we have, make a decision as to whether it's going to be activated as level 1, 2, or 3 trauma. If it's something small, run-of-the-mill kind of things, they handle it. We don't even hear about it. But anything that qualifies as a level 1 or 2, we will hear about it. And actually, we have pagers that go off, and they warn us generally before the patient even arrives to the hospital with maybe 5-10 minute warning.
I know, I've gotten those alerts.
Right.
And so I know to be in the hospital.
Exactly, and that's what it does. It gives us enough time to sort of tidy up whatever it is that we might be doing, whether it be in the OR or on the floor, and send either one of our nurse practitioners or ourselves to be there if it's a higher level. So that we can be present. So when the patient arrives either via helicopter or via ambulance into the trauma bay, the people that they'll see there will be the trauma surgeon, would be the nurse practitioner on the trauma service, the emergency room physician, as well as the rest of the emergency department staff and nursing.
The room is reserved. They go right in. No waiting. Nothing.
We have trauma bays that are prepared specifically for traumas that are well equipped. And again, all the practitioners are alerted ahead of time. Except, of course, in the case of a drop-off or something like that, then you just have to handle what walks in the door.
Or something.
No, we're talking about when you're notified by they're being picked up by ambulance or by helicopter.
And that's fantastic service, and it's somewhat that way throughout the country. Obviously, some places are better than others.
Right.
You know what I mean? I've been part of this system, and I just think you guys are doing a great job there. And I've, of course, operated on many of those patients over the years. And the operating room is ready to go, has a room ready, anesthesia is ready. So
for any level 1 traumas, absolutely. As a matter of fact, the operating room staff will come up. The anesthesiologist will be present. The circulating nurse will be present, and then the decision can be made immediately whether the operating room needs to be opened up for the patient to come down.
So what's the most common injury that occurred in say a group in the state of Indiana, for example, or in our counties? What's the most common type of injury we'd be looking at?
Well, so the way we look at trauma injuries when it comes to this is whether it's blunt or penetrating trauma. So we can divide it into 2 different categories. Of the blunt, most of the time it tends to be falls or motor vehicle collisions. Etc. There's some bicycle accidents that occur as well, some all-terrain vehicle accidents. And interestingly, out of all of those, over the last couple of years, we've seen those numbers increase. Except for bicycle accidents, those have actually decreased last year.
I think there's been a lot more awareness in this town.
I think so.
And we've raised some money, and I contributed, I think, $5,000 to bicycle paths. And they're all over this town. People are riding on them, walking on them, jogging on them. That's just fantastic.
That's actually a draw for people to move in here, all the bicycle trails.
Is it really?
Yeah,
it is. Hear that. That's very interesting. Businesses come here because they see our paths.
Right.
Yeah, I'm so glad. I remember 5 years ago, probably gave $5,000 to donate. So did many other people. I was not the only one, and many people very significantly. And I see people early in the morning walking on them, their children out there. It's just fantastic.
Yes.
This is getting. After all, I'm a wellness doctor. You don't think I wouldn't like that? I love that. I just love that. Recommend that. So falls is.
Yeah, falls, blunt injuries is the most,
Yeah.
but we have seen quite a rise in penetrating trauma, and that's
Yeah.
usually going to be things that you see, you know, with violence,
Yeah.
either, you know, what we call the knife and gun club, you know,
Yeah.
stabbings or shootings,
and
etc.
I
Yes,
noticed
we
the
have
other
seen
day
quite
there
a
was
rise.
another shooting, and it's about the. I mean, it's a pretty high number. We're getting.
Sadly, in the
yeah.
year 2010 to 2011, the homicide and assault rate increased by 25% from the year before.
Wow.
However, in the year
Yeah.
2011 through 2012, so a
Yeah.
year ago, it
Yeah.
increased by 93% from the year before. So we're
Wow.
seeing quite a jump
Well,
in penetrating trauma.
Yeah, this is very sad to hear, and we saw the news again last night. You know, what happened at the Navy Yard in D.C. and
Right.
13 people killed. So, penetrating injuries. I mean, I was in the Vietnam War. I'm familiar with that. I was in there 2 years. So I treated a lot of those. Of course, prevention is the answer. Some die, some are paralyzed.
Right.
I mean, what do you see from the shootings? For example, brain injuries.
Well, you mentioned it. I mean,
Yeah.
you can see any and
Yeah.
everything. And what happens
Yeah.
with these high velocity projectiles is that you
Yeah.
have multiple injuries usually.
Yeah.
It's not
Yeah.
just an isolated injury. You know,
Yeah.
oftentimes you'll see something that penetrates
Yeah.
the abdomen, and so you have
Yeah.
to worry about some of the solid organs as well as the hollow organs. So we're talking, you know, kidneys injury sometimes, something in the retroperitoneum, so sort of outside in our back of our abdomen,
Yeah.
as well as colonic or intestinal injuries.
They end up with a bowel sticking out, a colostomy.
Absolutely.
Or hit the heart, make it be killed.
Absolutely.
Or the lung
or
end up with
sometimes
the tube.
correct, and it also neurosurgery oftentimes
Yeah.
will be involved if it affects the spinal cord as part of
Yeah.
that, or like
Yeah.
you said, you know, the head.
Yeah. Yeah, I've treated a lot of that over the years where people are, you know, permanently paralyzed from the neck on down, arms and legs. Sometimes all they can do is breathe in a respirator for life.
Yes.
And sometimes paralyzed from here on down, move the arms or paralyzed legs, and lumbar area. A lot of them have chronic pain problems because it severs the nerves, and they have pain the rest of their life. It's very significant injuries. Although I've seen remarkable recoveries too.
And we see that.
You know, speaking about that, I saw a trauma. Actually, I saw a individual at a pool in Naples, Florida, and I talked to him, quadriplegic, maybe 50 years old, and we were watching some swimmers, and I asked, and he had been involved in an injury, and I asked him if he ever had been able to make a living. So I'm trying to give some hope to people. You know what he said? He was the inventor of Post-it notes.
Really?
Yes, he owned printing companies all over the world. And if you ever watch the Minnesota basketball team, you'd see him sitting there in a wheelchair. Unfortunately, he's died since then from an accident on ice. Yeah, but that was kind of interesting. I invented Post-it notes, and I saw in the New York Times when he died. It was a true story. So people with severe injuries, they can still, survive.
Well, and the other thing that we say is, obviously we didn't cause the injury. We're there to try to help. But really, as physicians, we do the best we can to help the body heal itself. And in the end, it's really up to God.
Yeah, you're right. There's a doctor living within all of us. I always tell people. I came from Herb Benson in Boston. Yeah, he helps us heal. And God and the doctor living in us can do a lot of healing. So but prevention, obviously is a big thing.
Prevention is a huge part.
It's a huge thing. We were talking about injuries, falls being the most common. The most common thing that I was seeing is elderly people taking a fall, and they're on either Plavix or Coumadin or aspirin, all three. And unfortunately, many of them didn't have to be on it anymore. They didn't see the doctor, didn't keep track. 5 years I've been on Plavix or Coumadin, didn't go see the doctor recently, and didn't check the bleeding time.
Right.
They took a light fall, totally survivable thing, but now because they're on blood thinners, it turns into a life-threatening thing.
Right, and that's one of the things that we do see a lot of is, like you mentioned, older
see it
people
too.
who have been on some sort of blood thinner, generally Coumadin for whatever. It could be a heart condition like atrial fibrillation, and then they fall off a ladder as they're working in their home, and now they have a significant head bleed. That
and this
could
is
be life-threatening.
very common. Every time I was on call on the weekend, I would see some of that. So I'd be very careful. Anyone who's on a blood thinner, make sure, number one, that you need it, double check it, talk to the doctor, know the side effects, know the signs of if it get out of hand, you're starting to bruise, you may need to get it checked, and you should always regularly check your clotting time, which a significant number of people don't. I meet people who've had a major injuries, been on their blood thinner 5 years, and when I check it all out, I'm not sure they need to be the drug in the first place.
Right.
I mean, how much do I increase the risk if I don't take it? That's the thing they got to know. And what I'm saying is frankly, an individual needs to participate in their health care. That's part of my wellness teaching. Number one, the new paradigm of medicine is you have to participate in your health care. Do I need the drug? Have I seen the doctor lately? Am I having side effects? I need to know the side effects. You have to participate. Can't just be passive, because these injuries occur again and again in falls. And people, especially as you're getting a day older, it's very important, and I'm familiar with that. and I've been doing, and I suggest to people, especially in this balance thing and taking falls, to learn what core exercises are, to strengthen your core, especially for women. If they have a compression fracture from a fall at age 60 from osteoporosis, you know what the death rate is? Within a year, 1/6 are dead. Yes. So core exercises, which you can do at home. I do them at one of the exercise places almost every day. I have 20 core exercises. Just go YouTube, core exercises. All kind of videotapes.
Right. And just to expand on what the core is, it's basically your abdominal muscles and your back muscles. And a lot of times people will focus on the abdominal, which is good, but it's only half. We have to focus on our back.
You're exactly right. You need to strengthen the perineum and learn the exercises, the perineum, the abdominal musculature, the paravertebral musculature. The core is all the musculature in this area, including your buttocks. And I think it's very important to do that, especially in the elderly, because, for example, to get on a roof on a ladder at any time is not a good idea. Somebody should be holding, somebody should be watching you. To me, cleaning out your gutters should be done by an expert. Pay them $35, $40, whatever, to clean your gutters. You get up yourself. You may end up in a nursing home. Fall off a ladder can put you in a nursing home. Once you break your hip, the odds of leaving the nursing home is not very high.
No.
It's 50% maybe.
Yeah, I think and I'm pulling back from previous training, but it was close to 60% mortality rate. Not necessarily because of the hip fracture, but more so because of all the complications that come afterwards, the debility, the pneumonias, the infections that you get because you're not moving around and taking deep breaths like you used to, the weakness in general.
I think you're absolutely right. And so you've seen a tremendous increase in penetrating injuries from gunshots and things of that nature. Interestingly enough, I wrote a book called The Call of Life, and I have in there the 20 prescriptions that lead to a good life. I've never shown them to you, but they're posted outside the Children's Criminal Justice Building on a statue that Hector Garcia did. And at the bottom, machine guns and guns that have been used in crimes. The police gave them to us, and the statue of flame to the top of the dove. So, and this code really is about eating behavior, and I've been trying to get into the school system, the Rudy's 20 prescriptions that lead to a good life, and some of that. I mean, what else are we going to do with the shooting? There's no way we're going to get all the guns, so I think we need to work at behavior.
Absolutely.
Education. And I'm trying to get the school system to adopt that. But they're written on the statue in front of the Children's Criminal Justice Building. If you ever drive by, go see a beautiful statue. There's some benches to sit down. You can read them on there. I just throw that out because, to me, it'd be very. I know the NAACP has looked at it. I mean, we're all involved in this, you know. But they would like the schools to teach it. Who wants to teach it after some of these things occur?
Right.
Let's teach it to the kids, and kids obviously under stress. You know,
and I think one of the reasons that we're seeing also less, for example, I mentioned that overall trauma is increasing, the percentages that we're seeing, but things like bicycle and ATV accidents are actually decreasing. I don't think it's necessarily that the number of accidents are decreasing, but certainly the number of level of activations as a result of the injuries are decreasing. In other words, people are beginning to wear more helmets.
Yeah, better treatment. I think the helmet thing's a big thing, and we want to speak about this because I certainly have treated a lot of motorcycle accidents, from the ones we saved to paralysis to death, and the helmets, of course, decrease the injuries tremendously. And I mean, I really was adamant about that. But when I speak to motorcycle riders, I mean, first thing to consider is not to ride the darn thing in the first place, because you're meeting these big SUVs today. I mean, who's going to be the winner? I've seen many accidents from deer running out and causing fatal injuries. And but then again, I've spoken to the motorcycle riders, so and the joy that they get from that, I kind of softened my stance in terms of using it. But let's use safety precautions. You know, when it's raining, when it's snow on the ground, they're riding motorcycles, and early in the morning when the fog is out and the deer runs out. So think first. What I'm saying is, think first. So I'm not totally opposed to motorcycles at all, or bicycles, but put a helmet on, and we have all these beautiful bicycle paths. Avoid the street, because, I mean, personally, because I've written 3 books on pain and narcotics and things, so I know what's driving around on the road out there.
Right.
I'd say 10% of the people driving on the road today are drugged up in some manner.
Whether legally or illegally.
Legally or illegally, and most of it actually is legally. It's this combination of 10, 20 different drugs, and some are elderly, some don't know how to drive, and you're riding a bicycle down the road. You're at a risk. You're at a risk.
And really, just to make a parenthesis there, is that even if they're taking narcotics legally for pain control, for post-operative management of some sort of pain, you shouldn't be operating heavy machinery, driving a vehicle, making important decisions while you're taking this medication. Yeah,
people do not realize what I see a lot of, and I've sort of become a little bit of an expert on that because I've written books on it, and on narcotics and pain. I've written 3 books. And you can get them on Amazon Books, is the interaction of these drugs. People don't realize that. They're on OxyContin and Vicodin, and they're taking a Neurontin with it or phencyclidine with it, and they're intermixing, and their death rate and injury rate goes up tremendously. And the patients taking them, especially if they're starting to get addicted, they're traveling down here. They almost can't help it. Do you know what I mean?
Oh,
and their provider and their friends and their relatives have to make them aware how dangerous that is.
Well, there's something called upregulation of the receptors. So, and I try to explain this sometimes to people who tell me, well, I've been on pain medicine for a long time, so I need more in order to cover the pain now after surgery. And they're absolutely right. They do need more, but the reason is that they've been taking pain medicine for so long that their cells, in a way, become used to and numb to the amounts that they're getting, and therefore you need more in order to cover that.
They've developed a term called tolerance.
Correct.
And you have to up the medication, And I'd like to just generally throw out there too, while we're on that subject, not to accept a narcotic prescription unless you have cancer, or even there you got to be careful, because I've seen people cured of the cancer and now they're addicted to the drug. I've seen 2 people like that. One died recently, a friend of mine. They were cured of the cancer, but died from the addiction. Didn't wake up one day from the narcotics. So even in cancer, you got to be careful. Except for acute trauma, you get a broken leg, a ruptured bowel, or a major injury, take a narcotic, but there's an end point.
Right, short-term medication
but to
with an end
accept
point.
it for fibromyalgia and minor headaches, short-term or not at all, because when you become addicted, you can't help it. And the decision has to be made by a provider or a relative or somebody. The person that has become addicted is a decision where, you know what addiction is? They're so low. Mother, Father, God, the Pope, Mohammed, whatever, means nothing to them. All they want is the fix.
The drug.
Is the drug. So prevention here is critical.
One other point that I wanted to highlight about that is that something that people don't realize is as you become older, these drugs need to be metabolized somewhere, and many of them are metabolized by our liver. In other words, broken down and gotten rid of from our body, and as you become older, those mechanisms aren't as efficient. And so even a dose that you might have been used to taking in the past might not be something that your body can handle anymore, and it tends to linger in our system and causes other problems as well.
I think it's a great comment. That's a great comment. And you don't know how a 60, 70-year-old going to tolerate it. And I see some of them. And part of the problem is they're seeing many physicians. It's not just one family doctor anymore. They're going to 5 or 6 different doctors, and if you don't participate in your health care, you don't know the interaction of all these medications, and they'll fall off of things and slip in the bathroom, and before you know it, they're living in a nursing home. So this interaction of medication, your family members, I love it when I see a patient, even in intensive care, that there's someone sitting there with a yellow pad like this and a pencil, because there's a team of 10 different doctors coming in there, different, you know what I mean?
Right.
And the person sitting there with a yellow pad and pencil many times knows an awful lot. And so when they come to my office, I see grandma and there's daughter sitting there. I just love that. I love that combination, and I think that's important. Because the elderly can't remember all that.
No.
And many of us can't remember all that.
and part of that is part of the healthcare system as well. There's so many providers involved in a patient's care where there's so many subspecialists. You have somebody that focuses on one part of the body, another specialist on another part. Next thing you know, sometimes it's a little difficult to keep all the parts communicating.
It's the nature of it.
Right.
And we're all aware of it, and it's the nature of it. So I think medication is a big cause of it. Let's talk about children a little bit, which I think I treated many children for injuries over the years. And do you see children injured quite often?
We do, actually. We do have a good number of patients that are pediatric. Yeah, the pediatric population, certainly. I have a couple of statistics here also from the year before and last year as well, so 2011, 2012. And again, with the pediatric traumas, we're seeing those are overall on the rise. Interestingly, you can see patterns of time of year. Yeah. So depending what time of year, you'll see the number of traumas go up or down. Correct. Yeah. In July of 2012 to the present, actually, the number of pediatric traumas dropped, but overall, between adults, it actually went up by 29%.
Is that right?
Yeah, but it was interesting to see that the pediatric traumas dropped. Otherwise, they've been increasing.
Yeah, and very important for children, of course, and even tricycles, bicycles, to always wear a helmet.
Always.
I was in France maybe a few years ago, and actually it was Monaco of all things, and I saw a child suddenly come around the corner riding a tricycle, just going a mile a minute on this tricycle, but had a helmet on, had ear things on, had a chest protector on, had an elbow thing on, and had knee pads on. And I wish I'd taken a picture of that, because I thought, I think that mother and father really loved that child.
Yeah,
I couldn't believe it.
I was going to say, you almost hit him with the car, but at least he would have been protected.
I've never seen it since. I've never seen it since. But that sort of stuff, they may have maybe the law there. You know what I mean?
Right.
I don't know. But I think it's extremely important in children for protective gear on them, and to keep them away from the street, because I see children. Little children playing in the street, and remember 10% of the people driving a car, and even the rest of them, it's dangerous, little child.
Sure, it's not even because the child's being reckless, it's just, the child's doing everything right, and there might be a reckless vehicle. Same
with motorcycles, helmets or not helmets, they get hit by SUV, it's a problem. I think a good habit when driving, which I really, at my tender age, I'm not sure I did it, although I've been in very, very few accidents. But recently, one of my partners was killed. A retired partner, driving a smaller convertible, came around the corner and bang. I mean, that was the end of it. So I came out of Starbucks 2 days later, and a similar automobile, black, comes down the road, and man, I almost hit it. And my son, neurosurgery son, reminded me, Dad, you always got to look twice. I never looked at it like that. Now, that's a good habit for you. Look twice. You look once, look the other way, and look again. Someone almost got me at Starbucks texting, a young girl. I looked right, I looked left, and I went ahead. Good God. And she was texting. Could have killed me. Could me, this texting business. And while we're on that subject, I mean, if any of your kids are doing that, don't let them drive. Just take the car. Just take the car, and they will, You got to watch. You got to have a real tight rule. If they're on the phone and texting, and they're 17 years old, for God's sake, just take the car. Otherwise, you may end up going to a funeral. And we've seen it. You've seen it.
I've actually seen that in trauma.
In trauma.
A few years ago, it was a young lady.
Yeah.
She was in her early 20s. She had a child in the car, and she was actually texting her mom
Yeah.
to let her know that she was on the way home. But unfortunately, she was driving while texting. Now, her son was restrained in the rear, passenger side in a child seat.
Yeah.
So the child suffered some injuries.
Yeah.
The mom had a severe traumatic head injury.
Yeah.
She survived, but she was not the same person. Completely different person.
And we see many people, paralyzed or go to a nursing home for the rest of their life. We've seen plenty of it. And but in general, common sense. I personally, we have certain laws about alcohol and driving. I would strongly suggest if you're going to have a drink at dinner or something, you don't drive. Have a designated driver. I mean, my wife, I go to dinner. I mean, if I'm going to have a glass of wine, she'll be driving home. I mean, I realize would not be within the limit of intoxication, but I tell you, even one glass of wine changes the way I think.
Sure.
I'm more verbose. I'm saying things I normally wouldn't say, and that's for all of us. It's not just me. And I fully realize it. If I'm going to drive, I don't drink much anyway. Maybe a glass of wine now and then, but even that affects me.
Absolutely.
So any drinking and driving, I think, should be out totally.
With regards to major traumas, there's been lots of studies that have looked at the amount of people that are intoxicated either with drugs or alcohol. And one of the numbers that I saw, because they vary in the literature, but I've seen up to 40% of traumas are somehow drugs or alcohol are related.
It's not a thing. Let me repeat that. 40% of traumas are related, and it probably is a little higher than that. Actually.
It probably is.
Probably a little higher than that, related to alcohol and drugs. So we could reduce the trauma rate. I mean, about 50,000 people a year die from trauma, probably in this country. I think it's around that.
That's a high number, yeah.
It's somewhere 30 to 50, right? Somewhere in there, 40. Half of those could be prevented, isn't something? And then you add to that, and this is a true statistics because I've written books on narcotic prescriptions, 18,000 people a year die from narcotic prescriptions, more than from the street drugs. That's a true statistics. Yeah, unbelievable. And we see, and this is not from trauma, but we see a significant number of babies born addicted to narcotic medications. So I like to, and I realize this isn't about trauma, but this is so important, that if you're a childbearing age, you ought not be taking a narcotic medication because you might become pregnant, and then your child could become addicted. Yeah, I mean, we're talking about statistics. Somebody ran a study at University of Michigan. 4% of the babies born in this nation are addicted to narcotics. Yeah, 4%. Certain states, certain type hospitals, depending where they're at, where in the city they're at. West Virginia, 20%. Yeah. In certain hospitals, 5-6% of the babies born have to be put on methadone or morphine.
And that's a high number for kids that shouldn't have any other.
And many of them end up being
abnormality.
It's so. Please, if you're a childbearing age, narcs are not part of your life unless there's an acute injury or something like that. But take it chronically for fibromyalgia or headaches, it's just not a good idea. I see it. I've seen over the years, and you probably have too, abused children, where they're abused by a family member. So if you see any of that, actually it's the law. You got to report it. You have to report it because the next injury, the child may die.
And that's another type of trauma that we haven't talked about right now.
Let's talk about that.
We mentioned a little bit about assault and homicide in adults, but it happens in children.
Yeah,
it happens in children.
And
physical abuse.
Yeah, physical abuse, and it's not uncommon. What do you see? Once a week? I see it once a week almost.
Yeah, sometimes it's a little bit difficult because when they present, there's always a story that comes along with it. Nobody comes out and flat out says, yes, I beat my child, or the child I was babysitting, etc. But CPS gets involved whenever there's a questionable injury to a
it's
child.
social service.
Correct.
And it's the law. And the law, I'll tell you, is extremely strict. The law is extremely strict. I have seen children just disappear from the family if they find bruising and they can't explain it. You know what I mean?
Mm-hmm.
You find a number of bruises over the body, and I tell you, the protective services, the children, you lose your children like that. So you got to report every injury to your child, and it can happen. My kids had injuries, you know. Had a babysitter and fell off the bassinet. It happened. Yeah, but the babysitter didn't tell me about it. I found a lump there a few days later, and then she confessed. Oh yeah, and those things happen. So when you bring in other people to take care of your child, and in today's society, you have to. People need to go to work, make a living, and then they have a stranger come in the house. Maybe there's a divorce, and the danger rate can go up there. I see a lot of that, where other strangers come into the home, staying overnight or something, and the child ends up with unexplained trauma, including deaths. Yeah, I've had children over the years from pediatric trauma. I've been there 44 years, so I've seen it. I've seen children be blinded from it. I saw a child that was blinded, had a tracheostomy, had trouble moving arms and legs for life, living in a nursing home from having been beaten by a boyfriend of the mother. And
at my time at the University of Michigan, I spent a lot of time at the pediatric ICU at Mott Hospital, and it's a sad note, but the number of deaths that I saw from the mother's boyfriend,
quite a lot. Yeah, it's not uncommon. Matter of fact, when we were talking about the narcotic medications, I was sitting at a restaurant at, I think it was Lake Wawasee, and there was a nurse, pediatric intensive care from Wishart in Indianapolis, and she said 1/3 of the babies she was taking care of were addicted to narcotics. Told me that. Just think of that. Yeah, she told me that. Yeah, very nice lady, and I was having dinner about two or three seats away, and when she realized I was in it, she told me that. It just unbelievable, and of course these children are more likely to become injured and everything else because they're
the environment that they're in as well.
The environment that we're in, and in teenagers, talking about childhood trauma, starting to drive, as we all know, every parent just shakes because of the danger, because they're not experienced. I myself was an inexperienced kid from New York who finally got a car at IU. I started driving when I was like 20. You know what I mean? I wasn't one of these Indiana kids that had a car and
been driving.
And been driving,
14,
grew up that
15
way,
years
and it was difficult to have a date. I didn't have a car. Oh yeah, I'll be honest with you. They had the old stick shift in those days. I drove on the sidewalks of Bloomington, Indiana. You know what I finally did? I just parked it. I remember when I got in med school, I was right in front of the old IU med school, and I was at a light right in front of the med school. And the stick shift, didn't know how quite to do it. And the car rolled backwards, and I still had the white card. You had to have a licensed driver with you, and the car rolled backwards. Guess what? Hit a police car.
Oh boy!
Boy, he jumped out of the car, but when he saw the learner's permit. But that's what kids have to go through, and how dangerous that is. I mean, they can kill themselves, they can kill other people, and speeding, of course, is a big thing. I mean, people are driving down the road 80 miles an hour. And anything happens, it's tough to correct it. So I think reasonable speeds are important today, especially early in the morning. Looking for deer on the sides, I do all the time, and try to avoid. But people have to go to work. You know what I mean? But to look for a lot of deer around here, and to look for them and to be fully alert, I think is a pretty important thing. Of the injuries that, as a neurosurgeon, I mean, what do I treat? A lot of injuries to the head.
The head and the spine.
Yeah. We have these concussions, and you hear a lot about them in football injuries today too. Where they're discussed a lot more. But concussion, you get a CT, you see nothing. Okay, then there's cerebral contusion. That's a bruising of the brain. We do a scan, we see a little bit of blood and bruising. And in elderly people, where the brain over time, happens to all of us, the brain shrinks a little bit. If you drink a lot of alcohol, it shrinks a lot. If you take drugs, which most people don't know, because I've studied that field quite a bit, I take narcotics a lot and drugs a lot, the brain shrinks too. Yeah, that's not well known. Alcohol does it. Literally shrinks the brain, so there's a lot of room up there. So if an alcoholic is on, say, aspirin, and it doesn't, the blood doesn't clot too well, even a light injury can result in a major blood clot. And it may not show up for a while. That's if the clot's between the brain and the skull. It's called a subdural. Subway, underneath, submarine. It's on top of the brain, but under the membrane that covers your brain, called the dura. And a subdural, they can be acute, following an injury, just fresh blood, but they can be chronic. A patient has hardly any symptoms, but he's got a subdural blood clot that big underneath there, slowly pushing the brain away. May come in barely with a headache, may have no headache, may come in with a seizure. So to get a scan on people like a few months out, grandpa's personality is changing, and he bumped his head 3 or 4 months ago. I see a lot of those. That bumped his head through, it may be totally forgotten. Comes to the emergency room, he's acting like a stroke. Can't move the left side very well, a little bit dizzy, and I get a CT scan.
And you find that it's a chronic
big subdural.
Bleed,
yeah, and we can sometimes just make a hole, drain the blood. Sometimes do nothing. And sometimes you got to take him back to surgery repeatedly because the brain is not expanding to fill in the space. No, not swollen that much. The chronic ones are not swollen much. The brain won't fill in the space, and more blood accumulates back to surgery again. And I've occasionally operated somebody 5, 6 times. Oh yeah. So a little minor bump, and someone has a shrunken brain to begin with, and a little bit of a blood thinner can turn into a major deal, can end up in a nursing home. Can end up dying from the darn thing, and it's interesting. Acute, you can have injuries on top of the dura. That's called epidural. You've seen them. Not that common, but let me tell you a typical story. You've got a teenager or a child. Let's say a 10-year-old child walks past a swing. The swing hits the side of the head. He's vomiting, got a headache, and you're thinking you'll take him to the emergency room, but 5 minutes later, kid's fine. He's out playing baseball and he's doing great. Then all of a sudden he falls to the ground, starts vomiting, and you open the pupil up and the pupil's dilated. Watch out. That's an acute subdural. That kid's close to death. And that can take a little bit of time. There's a little interval of time, maybe an hour, maybe during the night, child's vomiting the guts out, and you say to yourself, wait a minute, something isn't right here. He had that injury 6 hours ago. I didn't make much of it. That kid's got to go to the emergency room.
Absolutely.
Yeah, that kid's got to the emergency room. We got to have a scan, and it could be a big, fresh epidural hematoma. They rapidly progress, and I run them to the operating room, and I've saved many a life that way. I mean, it's not a common thing, but it does happen.
And when it happens, it's a big deal.
It's a big deal. Yeah, it's a big deal. So you have to pay attention, to the injuries that occurred. Especially, I think you have to see the amount of injury. They fall down a ladder, you probably best get a CT scan, no matter who it is, just to be sure, because some of these complications can, develop hours later. They don't all occur, right then and there. What's a recent severe injury that you saw? What's the most recent one? A major accident that you saw?
Well, I've seen a lot of them lately, but one of them was a gunshot wound. Yep.
Yeah.
It was 2 bullets, but one went through the abdomen, injured the what we call the retroperitoneum. I mentioned that before, sort of
That's
where the back muscles.
Back of the guts, where the muscles are.
Correct. Caused
the core,
hemorrhage.
near the core.
Exactly, what they should be exercising.
Yeah.
Injured that area, so there was a hemorrhage there.
Yeah.
Went through the abdomen, so there was 3 holes in the bowel.
Wow.
Also went through the spine, so there was residual paralysis. We took him back, rushed him back to the operating room.
Yeah.
Were able to fix the inside of the abdomen.
Yeah.
With the neurosurgical part, actually, I probably shouldn't give too many detail on the program, just so that it couldn't be identified. But long story short, just to keep it brief, is that there were some residual effects from the spinal cord injury. Correct.
And I would imagine, from a surgical standpoint, that is just got to be difficult surgery, because all the blood around, all the swelling around, nothing looks the same.
You don't have the nice anatomy.
You don't have the nice anatomy there.
No,
I mean,
you got
to run the bowel, so you can find the hole.
And you've got limited time.
And you got limited time. You've had blood loss, the big hematoma from the spinal injury.
Right.
That takes great skill to save that person's life. And just to go further down the spinal bit, I see a significant number of patients in my time of experience where they develop a dislocation of the spine from the injury.
Sure.
And sometimes they have it and go home, don't even know it, and it's so slipped after they left the hospital. Now they get numb in the hands, they got to come back, get the x-rays repeated. So trauma can be tricky.
A tricky thing, sure.
A tricky thing.
Right, and a lot of times, like you said, as you won't see the immediate effects of the trauma, it's down the road that you start seeing, maybe residual effects or things that are secondary to the trauma.
Got to come back to the emergency room, and especially if they...
Or even just in follow-up with their physician, they say, I thought this problem was taken care of, and now I'm still having issues with this, and you kind of look into it and you realize that there was maybe an underlying problem that we didn't see the first time because of all the other injuries that were there. Yeah,
now I had the most critical question. If Michigan State is playing University of Michigan, who do you root for?
That's pretty easy. I'll tell you what my answer is, because I got asked that a lot.
Yeah.
I have nothing but great things to say about the University of Michigan with regards to their medical system, with regards to the education there. Yeah. Second to none.
Is that right?
Second to none. It was fantastic. But when it comes to sports, it's clear to me it's green and white all the way.
That's great. That's great. Yeah, I went to to IU and I went 9 years to Indiana. It wasn't because I was stupid, but I was a kid from New York. Came there. I saw a picture of Bloomington. I saw all the trees and everything. I thought, Jesus, this is a great place. So I went to IU because of that, and I went to Georgetown University for my training in neurosurgery.
Yeah. So I'm back to the East Coast.
Yeah.
And then you came back here.
Yeah, and then I went to the Vietnam War for 2 years, Portsmouth Naval Hospital, and I ran the neurosurgery service there. I have some good news for you. Dr. Donald Reed, the head of the trauma service, finished his surgery and is joining our program here. And I'm going to hand him the last 10 minutes here to review statistics and I already mentioned to them how impressed I am about what you've done and the team you've put together. The audience knows that pretty well. So I turn it over to you, Dr. Reed.
Thank you, Dr. Cashman. Nice to be here. Obviously, you've met Dr. Rivas, our newest partner in acquisition from the University of Michigan and Michigan State before that. We have Dr. Santa Rosa, who's joined our trauma team from Parker Memorial in Dallas, where they famously took President Kennedy after he was shot. We've just acquired our third mid-level provider, so we have an entire gamut of healthcare providers to take care of trauma victims. And you already heard, I think, about the new helicopter being added, and that's basically because of the increased volume is what we're trying to handle. Now, I brought some graphic representations if your audience wants to see them. I don't know if we can focus in on this at all.
Why don't you tell us about it a little bit?
Okay. Basically, what we've been studying is following trauma volumes for the last 5 years, and more than just growth in the city and the county, both of which we have seen in Fort Wayne and Allen County. We have seen continuous growth in the trauma service. So there is some suggestion that there may be an increase in the volume of trauma in the area, particularly in this area in penetrating trauma. There's some speculation on the part of the local police department that there's increased gang violence related to drug trafficking. And there's some speculation that that may even be based on gangs located outside the Fort Wayne area fighting over the Fort Wayne market. So I guess it's capitalism at its best. Yeah. In any case, that's afforded us the opportunity to expand our skills and services and personnel to provide adequate care for injured patients in this area needing trauma care. One of the newest areas I think we're trying to concentrate on are patients who are on anticoagulants, which we have a large cardiac population in our area, and we're seeing patients from falls, as you all know from your career as a neurosurgeon, lots of intracranial bleeding. And now there are a whole host besides the usual players, the Coumadin and Plavix and aspirin, that have been around with us for quite a while. There's a whole new list of anticoagulants. So we've been working with our colleagues in the Emergency Services Division to come up with drug regimens and methodologies for reversal of these anticoagulants, so that when a patient sustains what may be typically non-life-threatening trauma, that they may develop life-threatening hemorrhage from being on the anticoagulant, as you took care of probably countless patients in your career.
We covered this subject pretty darn good, but it's nice to hear it again.
Right.
Because we want the patient to participate in the health care, that they
Correct.
know that they make sure that they need to be on this drug.
That's correct.
And not to take it
In
for
fact,
5
you
years.
and I discussed that very subject before, I think.
You bet.
Right.
We're seeing it together.
Right.
Yeah.
And so
Yeah.
there are some, thankfully, there are some new treatment paradigms that we're using. One new drug, what is it, Eric? Kcentra? I think we just...
Do you give it
which
at
is-
the scene of the accident, or you wait till the emergency
We
room?
actually wait till the emergency room. I
Okay.
think the ER doctors want to assess the patient and then apply it. And we have some new topical agents, one of which is Quick Clot. I hope we're not getting in trouble using trade names here, but this was something actually we had used when I was in Iraq, Rudy, the last time, and there was some, a lot of the deployed battlefield surgeons actually would have this in their armamentarium, and I specifically had cases where these topical anticoagulants would help to halt hemorrhage.
You had tremendous trauma experience in Iraq, right? And your rank in the Army at this time is?
0. I'm out of the Army.
Oh, yeah. What was it when you left? What?
Lieutenant Colonel.
Lieutenant Colonel. I mean, that's impressive. to
But
say the least.
just something of note is that a lot of the research for trauma
Yeah.
and the management of trauma operatively comes from the Army, comes
Yes.
from the military.
Is that right?
Yeah.
That's interesting.
A lot of the advances, yes.
Yeah, yeah. And we were discussing, the different types of injuries, falls being the most common again this year. You and I have been through this
That is
program
correct.
before, and we spoke a great deal about clots and the action of medications. A lot of people on 10, 20 different medications, and they're interacting and resulting in driving down the road in a fog. And one way I didn't really mention is falling asleep while you're driving.
Yes.
That's significant. And interestingly enough, I've had it happen twice. And I'll tell you, I have given a show on sleep. I read DeMont's book, this big on sleep, and I'll tell you, if you feel the slightest that you're falling asleep on the road, there's only one answer. You can't wait 2 or 3 times. Get off the road.
Pull over.
Pull over. That's all you can do. And twice it had happened. And I once coming back from those clinics, I went in Ohio.
I know.
And I woke up the last minute as I was heading right for a car. And I think God did that one. I really mean it. And I could have killed that person. So if you feel it at all, get off the road. And I think it'd probably take a nap, not just a cup of coffee, whatever method you use. But it's that critical. 2 or 3 times, then you're in a truck, kill yourself, and the driver to boot. So I think I'm glad we kind of brought that up, because everyone you talk to, I'm sure you've had an episode or so.
I've actually fallen asleep twice at the wheel, I think on the same night.
See, most of us, this happened to us, but a very solid rule. You feel that, I don't care if you got to go to work, whatever it is, you get off the road.
That's what I do routinely.
Routinely, do you really? Yeah.
Yes, I do.
Yeah, what do you go
Take a
sleep for an
nap,
hour,
yeah.
take a nap? Yeah.
Take a nap. In fact, I had a state policeman stop me and wonder what I was doing taking a nap. Said, I'm in a rest area taking a nap.
Yeah.
What can I say?
I think that's a big one. We spoke quite a bit about children's trauma, and you're seeing with me, we saw quite a few battered children, unfortunately. Is that becoming more prevalent because of the economic stress, you think? It seems to me like it is
We're
bit.
seeing a lot. It seems like we're seeing a lot. I don't know if you've noticed that since your arrival in town, Eric, but it's hard for me to gauge if it's more or we're just more sensitive to it, because everybody now is indoctrinated. You must call Child Protective
And
Services.
that's what we were talking about, that you know,
Yeah.
if there's anything even remotely suspicious, Child Protective Services is going to be involved. It's
and
the
I was
law.
telling
They
the
have to be
audience, and
involved.
I don't mind repeating it, those people are tough. if you don't bring your child in, they've had an injury or they've had 2 or 3 injuries, I tell you, they will yank the child out of the house.
You know, one thing that
we've seen
notice,
it like that.
And one thing that we did notice when I was at the University of Michigan is that there's also fluctuations with time of the year. Holidays are a high stress, high emotional time, and the number of physical abuse cases would spike significantly, especially during Christmas time.
Really? I
Yes.
never knew that.
Family stress.
The deaths that I saw in pediatric trauma as a result of physical assault on them were during Christmas time.
During Christmas times.
My.
Family dynamics. I'm sure some parents are economically deprived or can't pay the bills and they want to buy a present for their child and they become stressed. Incidentally, I gave a lecture last night, my monthly lecture series at Lutherans, and it was about stress.
Yeah, there you go. Yeah.
It's
a serious issue.
because it's very serious thing, and it affects family dynamics. And you can understand it. You can't make a mortgage. You can't afford your health insurance or whatever things, and it causes stress. And you have to really be careful in the family and maybe hug each other more than.
Instead of beating them?
Or
you're not supposed to beat them?
And you know what I mean? We need to learn from that and have some relaxation techniques that teach people. And I was teaching some last night. Incidentally, you won't believe this. I know you'd believe it. I put on my workout outfit because I told you I work out an hour every week, and I did some Tai Chi and Qigong for the crowd. A nice habit, so develop takes a minute. You know what I mean? Some relaxing activity to relax your mind. And then I have Rudy's 20 prescriptions for stress reduction, which you can download off the internet, because we all got stress. I got stress. You guys got stress. It's nothing horribly psychologically abnormal about it. It's part of life. If you have no stress, you're not alive.
Correct.
You know what I mean? But how stress works out in a family situation can result in people hurting each other. Man or woman, more likely men, but women do it too, and result in injuries. So to summarize our session on trauma here today a little bit, things that concern us, of course, are the medications, wearing helmets, and to think first. When you're going to do, there's an organization called Think First. You can get it on the internet, a good thing to look at. I've been part of that organization for years. But before you do some activity, you need to give it a thought. You know what I mean? If you're going to have that drink at dinner, who's driving home? Give it a thought. You're going to get in the ladder. Is somebody holding it for me? You know what I mean?
Right.
Getting on the roof, that's not for the average person.
No.
Experts, cutting down trees, experts. I rarely have seen an expert from a tree service with an injury. Have you seen any?
No,
I
they're
can't
always
remember.
Amateurs.
Yeah, it's amateurs that are doing this. Remember, I told a neighbor not to get in the roof. It was a lawyer, and he did, and he dived down, broke his femur, didn't work for 9 months.
Wow.
So roofs and eaves and ladders and things, not my ball game.
Right.
We know physicians that never worked again because of it. I know an excellent family doctor in Warsaw came down, ruined both his heels. He couldn't walk. And he no longer practiced medicine, and he was just the best. And so to think, before you do something, and think before you bring in strangers to take care of your children, because you just never know what's their history. You know what I mean? And we read about in the newspaper about abused children and things that have been injured and kidnapped, and because you don't know the neighbor down the way, so to really guard your children, I think is a really big thing. So tell me, what kind of case were you doing before you came? Can you tell?
Well,
no, maybe you can't discuss
let's just
that.
say it was a bowel obstruction.
Okay,
leave it at that.
We'll leave it at that. I don't know, and I know you guys have a trauma coming in. I understand.
We do actually right now.
And they can occur, any type of night. Eric, anything else you'd like to tell us about? And I know you had this many years to going to school. And
as did us all.
Yeah. How do you like Fort Wayne?
I love it.
Just at Fort Wayne?
I
you
personally.
were saying that. Yeah, you were telling me that.
Yeah, no, I actually I'm enjoying Fort Wayne quite a bit. Quite a bit. My family's enjoying it, and I think it's a great place to raise a family.
I came here from New York City. I love it here. I love it, and I've been here, 44 years, and I hope I have another 20 to go. But I'm now, and Dr. Reed and I have kind of been traveling because I know you consider wellness to be very important. We spoke about narcotics a great deal earlier. You and I have always agreed on that, that they're overused and be very careful. So I think we've summarized the trauma field for you pretty good. Feel free to send me a book. Meet me at Starbucks. I'm going to talk about some aspect of trauma. Ask me a question. We meet at Starbucks frequently, don't we, Dr. Reed?
Very often.
Who's bought who coffee more? Was it you?
I don't know. I think you've been buying it lately.
Oh, okay. Okay. That's a moment in space. Stress reduction. That's a moment in time where we take 10 minutes and reduce the stretch. So thanks very much for listening to us. And I hope you listen to our next show, which is on Comcast 57, 9 to 10 on Wednesdays. And the next one may be about the diet. The next one may be about pain. It's about the mind-body connection. I'm a mind-body doctor. I'm the medical wellness director now at Lutheran Hospital, and I thank them very much for offering me that job. It's a great place. I've been there 44 years, and everybody knows it's a great place. I tell you, it's a great place. And this is a great trauma team, and I want to thank you guys for being here tonight and helping part of the show. We do this once a year, and we'll do it for another 20 years, right?
You're welcome.
Thanks for watching. Namaste. Thank you. Thank you very much. The next one may be about the diet. The next one may be about pain. It's about the mind-body connection. I'm a mind-body doctor. I'm the medical wellness director now at Lutheran Hospital, and I thank them very much for offering me that job. It's a great place. I've been there 44 years, and everybody knows it's a great place. I tell you, it's a great place. And this is a great trauma team, and I want to thank you guys for being here tonight and helping part of the show. We do this once a year, and we'll do it for another 20 years, right?
You're welcome.
Thanks for watching. Namaste. Thank you. Thank you very much.